Hi guys, without much delay, congratulations to all of you who have subscribed to the medical PG curriculum. These kind of case-based, scenario-based approaches are one of the new such programs in our country, where each of the faculties who will be talking about important topics from their respective branches. So I've just also opened my chat box so that in case any of you have an online question during the live session, we would be able to answer them accordingly. So without further delay, I would want to introduce myself. I am Dr. Prashanth B Gandhi. I am the faculty in medical gastroenterology department in DocTutorials. So the topic I have chosen is approach to protein losing enteropathy. So now, approach to protein losing enteropathy. Why this topic? Now, we all are well aware of topics apart from these other topics where protein is less. So we know nephrotic syndromes, we know cirrhosis, we know malnutrition, we know so many other conditions. But then it is also important to keep protein losing enteropathy, or in total what is called as protein losing gastroenteropathy, in mind while assessing the patients who present to us with hypoproteinemia. Now, this topic is predominantly an approach to how to analyze a patient who presents with the pedal edema or malnutrition with predominant hyponatremia, hypoproteinemia, and we accordingly look into the approach and how to go about it. So the best way to analyze any approach in clinical medicine is actually to look at a case, try to dissect it down, and then analyze what exactly is happening. So in the same way, the depth of the information in this current topic would be to MD general medicine and internal medicine residents only. This could also be used for anybody who gets to see similar cases, and the level of discussion will be for general medicine MD students. And of course, if any of you are also interested to know more, you can always contact me personally and we can have a chat in depth. So let's start with a case that came to me. She was a 20-year-old lady from Bihar who presented with bilateral pitting pedal edema with a duration since 2 months, also had mild abdomen discomfort and nausea since last 1 week. There was no history of vomiting, loose stools, irregular bowel habits. She had no other systemic symptoms. Of course, there were some hypoproteinemia related hyperpigmentation on the shrunken skin or the tight skin that was there at different parts of her body. A picture will follow. There was no history of any other pointers. She used to consume predominantly a vegetarian diet with occasional, we also included fish around twice a month. So this was the picture when she presented. She had bilateral pitting pedal edema, and then you can also notice there is some form of hyperpigmentation that is there across. So that this was the presentation. That's it. So she was a young lady. So what we did was a basic evaluation at initial stages. So there was low hemoglobin, which was microcytic. The HB was 10.8. The total protein was 4.2 and albumin was 1.8. Now, I have just pointed out the important investigations. Okay, so total protein was low and albumin also was low. Now, this is something we'll have to look into. And while analysis of the peripheral smear, there was no eosinophilia, okay, and there was no other pointers of what to do next. So now here is a young patient with bilateral pedal edema, mild hyperpigmentation at different areas, and on evaluation there is low proteins and there is low albumin. So how do we approach this particular patient? Let's see. So as usual, whenever there are low proteins and albumin, we first think whether there is any conditions which is either reduced intake. So you can think of whether there is actually malnutrition, or there is reduced synthesis, which can be seen in chronic liver disease, or there is increased protein loss, which can happen in renal conditions like nephrotic, and there could be increased loss even in GI conditions, what we will call as protein losing enteropathy. Okay, so in this angle, if we start thinking what exactly has happened, then we should take a good nutritional history, then try to rule out other features of chronic liver disease and cirrhosis with portal hypertension, and then ask for basic tests to see if there is any renal loss. So that is how we went about doing the test. We did a cardiac test because sometimes there will be congestive gastroenteropathy. That is because of the high pressures, back pressure from the heart, there is more congestion in the GI system and there could be protein loss. So we did the cardiac workup and that was normal. She didn't have hypothyroidism. The renal functions and the urine test turned out to be normal. Abdomen ultrasound was done to rule out any obvious features of cirrhosis. The liver was completely normal, except for that there was mild ascites, which again could be just like how pedal edema, it could be completely explained by low proteins. Okay, the viral markers were negative. Sometimes, yes, HIV has to be evaluated, and that was negative. So because of the pedal edema, of course, unilateral will be more worried of arterial or venous system being involved. Here, the lower limb Doppler also was done for completion's sake, and it turned out to be normal. So now is what I would want to come to a more specific topic, that is protein losing enteropathy. Now, if you remember, it is a diagnosis of exclusion. Okay, so you have to rule out significant catabolic conditions where there may be a patient may be eating less because of maybe eating disorder, maybe cachectic. Those nutritional causes should be ruled out. Then you have cirrhosis and nephrotic syndrome, which should be ruled out. And then is where you start evaluating whether there is actually some form of GI loss, okay, which in specific term is currently today's topic. Around a century ago, they realized through some case reports of cases of Menetrius disease and Crohn's diseases, they realized that GI also plays a significant role in some conditions where proteins are lost. Normally, physiologically also, from the GI tract, 2 to 5% of the albumin that is normally synthesized is actually lost. But when there is protein losing enteropathy, the loss can even go up to approximately 60% of what is usually lost. Usually, physiologically, around 2 to 5% of normal albumin is actually lost in the GI system. Now, the physiological loss is attributed usually to the enterocytes, which are lost, and sometimes the secretion, the biliary secretion, pancreatic secretions also have proteins, proteases. So what is lost are generally because of these physiological components which contribute to the protein loss. Now, usually symptom-wise, grossly, these patients will present with features of pedal edema, malnutrition, Sometimes there may be also associated symptoms of primary condition. It could be Crohn's disease, it could be cardiac condition. Basically, based on what is the main disorder the patient probably suffers from, you can have additional symptoms. Okay, so when it comes to symptoms, always look at symptoms of hypoproteinemia in the form of pedal edema, or there could be associated malnutrition. And what we should be concentrating, really important, is any other specific symptoms of main etiology. Okay. Now, what are the different causes of protein losing gastroenteropathy? Grossly, the causes can be classified at least as conditions without ulcers, conditions with ulcers or erosions, and conditions due to lymphatic obstruction. Usually, those conditions without ulcers, it is usually because of some form of congestion in the vascular system or increased permeability in the GI tract, which could be paracellular pathway or a capillary permeability increase or a vascular permeability increase, which exudates the proteins. In case of ulcers, conditions which has significant ulcers, the reason is generally a protein loss because of the exudation from the ulcers. And in lymphatic obstruction, it is usually an post-intestinal or post-absorptive causes, which could be in the form of a retroperitoneal obstruction. There could be a cardiac congestion. There could be Budd-Chiari. So these conditions where there's increased congestion, there is some break of lacteals in the GI tract, which in turn leads to lymphocyte predominant loss of the lymph that is present just underneath the enterocytes. Usually, lymphatic obstruction also has some other clinical symptoms, like you can have retinal detachment features. There could be features, it sometimes can be even unilateral edema, or even sometimes involvement of upper limbs can be there. And lymphatic obstruction also from the blood picture, what you should look for is associated lymphopenia, because even the lymphocyte rich lymph is being lost. Okay, so these are the gross ways of seeing the causes of GI loss. So PLE causes can be broadly classified into these three phenomenon. Okay, each of them may have at least 20 to 50 causes, and they may be kind of mix up between most of the different subtypes of etiologies, and one etiology can have different mechanisms. But if you want to go about thinking of what are the subtypes, I have to think these are the three gross subtypes that you're going to get. So next, coming to the broad approach. First is, please rule out other conditions like cirrhosis, nephrotic syndrome, and malnutrition before considering protein-losing enteropathy. Then you have to confirm actually whether there is enteric loss. What are the different ways of confirming that there is enteric loss? Initially, the test of choice was technetium-labeled albumin scintigraphy, which was done. Of late, there is a simpler test and more widely which can be available, that is alpha-1 antitrypsin levels in the stool or clearance. Now, this is the current gold standard to establish a GI loss. If you want to go in depth, why exactly alpha-1 antitrypsin? Now, alpha-1 antitrypsin is a protein which is just like albumin in size, approximately 50 kilodalton. This is synthesized in the liver and is lost in the intestine, and it is neither absorbed or secreted in the intestine. So whatever is seen in the intestine is absolute value that the intestine is losing. So what we have to know is protein losing enteropathy, unlike a nephropathy, is non-selective protein loss. The entire proteins, irrespective of different components, is lost in the GI tract. Okay. So what we notice is proteins plus albumin plus all globulins. Okay. Literally all form of proteins are uniformly lost. So albumin will be low, globulins will be low, so many other proteins in the body will also be lost. But in the serum, whichever proteins have a very short half-life, that is, they're synthesized very fast, usually they do not show up in the loss. Like say even insulin is being lost, pre-albumin, which has a higher turnover, is lost, but those values do not become low. Retinal binding protein, again, it has a high turnover, so that levels do not come down. Okay. So even among globulins, all the IgA, MgE, everything is lost except IgE. So IgE, because it is synthesized very fast. Okay. So except IgE, most of the other immunoglobulins are also less in this particular condition. So this is about the current gold standard. Alpha-1 antitrypsin clearance is the current gold standard, but previously what we also used to use is technetium 99 technetium tagged with human serum albumin scintigraphy. This was X gold standard. Okay, currently the gold standard to establish enteric loss of protein is alpha-1 antitrypsin clearance. Basically, here we need two values. One is the serum alpha-1 antitrypsin, and the alpha-1 antitrypsin that is present in the stools over a specific time duration, which could be around 72 hours. Based on the stool levels and the plasma levels, the clearance values are found, okay, using some formulas. Next, once we establish that alpha-1 antitrypsin clearance is increased, then you know that proteins are actually lost, and then you try to focus what exactly, where exactly is the loss happening. So let's write the approach once again. First is you rule out malnutrition or nutritional conditions, you rule out cirrhosis, you rule out nephrotic syndrome. Then you establish, is there enteric loss? Now, enteric loss can also be, once it's confirmed positive, that is when you start evaluating from GI perspective based on what the patient has. You can also involve a cardiac test in between at the beginning stage itself, so that you rule out a cardiac condition also. Okay. After all this condition, then we consider GI system. That is when we do alpha-1 antitrypsin clearance, establish a loss, and once we know it is low, we start evaluating for the different causes. Usually, if a patient has associated diarrhea, we target the test usually predominantly to lower GI tract. We might have to do stool test for ova, cysts, clostridioides. Okay, we might have to do what are the fat levels to just establish is it actually steatorrhea that we are dealing with, and we might have to do a biopsy by colonoscopy. If patient predominantly has steatorrhea, which is basically more fatty stools, then we target the evaluation predominantly to a small bowel evaluation and pancreatic and biliary evaluation. So then you have to rule out chronic pancreatitis. You have to rule out and biliary secretion being low. You have to rule out proximal small bowel causes. So do an endoscopy plus or minus biopsy. We also might have to do a CT scan or MR enterography. And if there is any abnormality that is probable, we might have to go ahead with tests like capsule endoscopy to see for any lesions or enteroscopy to see whether there is any small bowel problems and take a biopsy. So enteroscopy is a kind of endoscopic procedure where we can even reach the small bowel. So this is the gross way of how we will think when a patient presents with protein losing enteropathy. Of course, if with all these basic causes we aren't able to find out what is happening, rarely we might have to go ahead doing, in some centers we have lymphangioscintigraphy, and lastly, if not the causes are not there in any of the routine tests that we do, we might have to even do a diagnostic laparoscopy. So this is the entire approach for how do we be dealing with a case of protein losing enteropathy. So most of the causes will be covered in this. So now I just wanted to show you how complex the chart of protein losing gastroenteropathy can be. But what you have to remember is still the principles. Those are diseases without mucosal erosions and ulcerations. Like say, for example, AIDS-associated gastroenteropathy, celiac disease, eosinophilic gastroenteritis, GVHD. These are few examples. And then diseases with mucosal erosions or ulcerations, which could be conditions like Crohn's disease as an example to be remembered. Then the lymphatic pressures get elevated in the third variety, say for cardiac diseases as the one classic example you guys can remember. Let's not go into too much depth. It's only a principle-based case. So we shall quickly go on to what happened to our patient. Now, in our patient, we knew that the urine cirrhosis, cardiac workup, all were negative. So we are probably dealing with the GI loss. So the moment we are actually going to post her for an endoscopy based on her symptoms, she on the night when she was actually prepared for a scopy for the next day, she actually had vomiting, and there were some kind of worms that she told that she had passed. So what we did is, in the endoscopy, rightly as the patient said, we could notice that in D2 part of the duodenum, I've already explained how to actually look at duodenum part 2 on an endoscopy picture and identify. So this is a picture where you see some in some kind of parasites which are actually there. There were multiple. The videos are there with me where there were multiple. Unfortunately, I'm just able to show you the pictures. And once we retrieved the parasites, to be more specific, they were trematodes. And this is a picture of the colonoscopy also, which we posted her for. You can see multiple slimy moving structures, which were actually fluke infestation. So we retrieved some of the flukes, and this is the fluke. And we also identified that it was Physiolopsis busky, and this is the gross morphology, and this is the what you get is the permanent mounting of the particular parasite that we got, trematode to be more specific. So we then also send the stools. Also, the stools were sent for sampling, and this is how the bile stain oval operculated eggs looked like. And to our surprise, there were even other species of trematodes that were found. One of it is this structure, which you are finding like this. It is actually held with a pencil-like structure for the picture, and we could see a trematode called as gastrodiscoides hominis, where a permanent mounting is this particular picture, and the egg also of that was positive, and it again was a non-bile stain operculated egg of gastrodiscoides hominis. Because these uh, trematodes are not quite commonly seen in our routine practice, we even confirmed the speciation by the veterinary parasitology department in Bangalore, and we even sent the pictures to CDC USA to confirm the identity. Apart from these two trematodes, the stool test was also positive for cysts of Giardia intestinalis and Entamoeba histolytica. The family members were screened and they did not harbor these infections. So this is a condition which is typical for a country or places with endemic parasitosis, where we can get multiple parasites in a single patient. This patient was ultimately subjected to treatment and is doing really well. Now, treatment for parasitic infections. Just to make your concepts clear, remember, guys, you need not know the entire table with answers for all the organisms and all the parasites. If you remember the mechanism and make some general rules, that is more than enough. Now, for this case specific, what I would want to tell is it is a trematode. Now, for most of the trematode infections, the treatment of choice is praziquantel. And exception is if there is Fasciolopsis buski, then the treatment of choice becomes triclabendazole. Just know this much. Do not know too much about this. You can read about its mechanism of action. What we had was Fasciolopsis intestinalis. Okay, so really for an intestinal organism, the treatment of choice is praziquantel, and exception is Fasciolopsis hepatica, that is the liver infection. For liver infection, the treatment of choice is triclabendazole. Okay, so here we treated our patient with praziquantel 25 milligram per kg. We also gave her metronidazole and albendazole because of the coexisting other common parasites. The treatment of choice for both gastrodiscoides hominis and Fasciolopsis buski, which is an intestinal trematode, is praziquantel. In view of her hyperinfestation, she was also given polyethylene glycol preparation to purge the dead worms in order to prevent intestinal obstruction. There were many dead worms. She passed stools over the next 3 days, and after that there was very good symptomatic improvement. She was showing a trend of serum albumin improvement, and she was discharged in due course. If you guys want to read more about this particular case, this case was published in one of the internal medicine open access journals. You guys can go through this particular article. And why specifically I had got this particular case history was to just tell you that even during your internal medicine days, please do not let go of your approach. This case was kind of published during my MD days, and I know that most of the students here who have subscribed for the MD PG curriculum are in your MD or DNB days. So your approach is important, and your interest onto a subject plays a major role in your future decisions of how you're going to see a case. And your physician mindset is really important when you go also to become a super specialist, and when you have to think of things in a very wide aspect. Okay, so this is a study which you guys can go through, whoever are interested. I would like to end this small session by a quote by Mark Twain. 20 years from now, you will be more disappointed by the things you did not do than by the ones you did. So throw off the bowlines, sail away from a safe harbor, catch the trade winds in your sails, explore, dream, and discover. So you guys have to dream big and have a goal each day, work towards your goal, and definitely one day you would be successful, you would be happy doing whatever you really wanted. So thank you for your time. If you guys have any doubt, I would like to share my personal number on this platform. Please reach back to us. My phone number, WhatsApp number is 74066484141. Okay, this is the number you guys have to get in touch with me. Thank you for your time.